Zoom, where is Zoom? وين هلا كان؟ Yes. Share screen. فيديو ما بتحطيني فيديو؟ بلى. Hello.
So,
you hear me?
Hello, Professor Nagi. This is Imad Shash. Yes, we hear you very well, and we can see your presentation. So, I was just introducing your presence. Professor Nagi Elsaghier is a well-known figure in the Middle East and all over the world in breast cancer. He's a professor of clinical medicine and the head of division of the hemato-oncology and the director of the breast cancer Center of Excellence at the American University of Beirut Medical Center. Professor Nagi will actually try to complete the rest of the picture about the metastatic triple-negative breast cancer, and he will give us a shed about the BRCA mutations in the metastatic breast cancer. Professor Nagi, we are eager to hear you.
Okay, good morning, everyone. It's really a pleasure to be with you. I'm sorry I miss you all in Cairo. You are really lucky that you don't have a lockdown that we have. And I assume you had a nice trip yesterday to the Nile. My task is to talk to you about BRCA mutations in the metastatic breast cancer. Those are my disclosures. I looked for, Dr. Hamdi just sent me his slides, but I didn't have time. Just to give you an idea that triple-negative breast cancer is also important in our part of the world. It does constitute about 10 to 15% of all cases worldwide. And in our part of the world, it is also important. This registry was presented interim, data at San Antonio by Dr. Hamdi Abdelazim. There is a variety of percentage of breast cancer triple negative in Middle East and Africa. I just put some slides that we had from Lebanon. We had several studies that showed that triple-negative breast cancer constitutes between 9 and 12% of all cases of breast cancer in Lebanon. This is similar to other Arab and Middle Eastern African countries, but it was a little higher in some other countries. As I said, therefore, 10-15% of all breast cancers. By definition, we have ER negative, PR negative, and HER2 negative. Cytokeratins are expressed in about 70% of these cells. We have expressions of PD-L1 also that we will talk about its importance later on. Those tumors are usually high-grade, high proliferative index, high mitotic counts, pure tubular formation, lymphocytic infiltrates. All these things also makes the tumor more immunogenic than others, and that's why we will talk about immunotherapy later on. In general, they have a worse prognosis, these patients worse prognosis. They present at advanced stages, more common in younger women, obese women, African women as well. If it's early, high recurrences within a few years. Frequently, they recur in the liver and lungs. Now, associations with BRCA mutations, 15 to 20% of triple-negative breast cancer patients do have BRCA1 mutation. And the BRCA1 mutated patients usually, most commonly, they are triple-negative breast cancers. This is just a slide that tells you in the BRCA1 up to 80-90% are ER/PR HER2 negative. Some of them also are not. And when you have a BRCA2 mutation, ER positivity is common, and about 10% of the cases have even HER2 positivity. 5 to 10% only of hereditary breast cancer are due to a mutation that makes the patient prone to develop breast cancer. 50 to 60% of those are BRCAs. The others are the other 50%. There are 15 to 20% familial breast cancer cases. Probably some of them, many of them are, hereditary, but we still do not know the mutations that they might have. And 70 to 80% are sporadic. Mutations occur on a chromosome 17, BRCA1, and chromosome 13 in BRCA2. We're going to talk about BRCA pathogenic mutations, not the variants of unknown significance. This is a list really of the BRCA1-2 mutations in various countries and worldwide, showing you that there are some studies, limited, but we do have studies in our regions that confirm similar or little less at times than what is known in general population. In Lebanon, we have seen that 11% of patients are triple negative in general. We have seen that BRCA mutation is most common in patients who are below 40 with a positive family history. And of the triple negatives, 11%, 11% of the patients were triple negative, and 25% of the triple negative had a BRCA1 mutation. The management, what I will be talking about now, is first of all, besides platinum, for chemotherapy in general, BRCA or non-BRCA triple negative breast cancer, in general, chemotherapy, the same recommendations apply. Those are our ABC guidelines. Now, in triple negative advanced breast cancer, regardless of the BRCA mutation, we have studies that show carboplatin comparable efficacy and less toxic, comparable, more favorable toxicity profile than docetaxel, and it is considered an important option. And at the last ABC, the panel had a statement that germline BRCA status, PIK3CA for ER positives, and PD-L1 for triple negative breast cancer, advanced breast cancer, are now included as important factors to take into consideration when we make a decision for treatment with advanced breast cancer. This is based, first of all, the role of platinum was established by many, many studies. One of them is the small studies. TBCRC009 study established the role for platinum, whether cis, 75 per meter square, or carbo, AUC of 6. It has a role in patients with germline BRCA1-2 mutations. And they looked at other mutations. We have other mutations, also have some homologous repair disturbance, in their cells, and there is activity of platinum compounds as well. Now we have the TNT study based on the fact that there is impaired homologous recombination repair in patients with BRCA mutation, and also some patients have what we call BRCA, some BRCA1 methylation, or low mRNA, or deficiency in mutational signature, basal phenotypes. They could be platinum sensitive. And homologous repair also repairs the lesions caused by platinum and PARP. So combining them both can make the cells amenable more to cell death. So we had the TNT study, randomizing carbo versus docetaxel in both triple negative and also BRCNS group. While we see that carboplatin did have an equivalent, effect, and it is less toxic than docetaxel. We have used it. It is really less toxic, much better tolerated. So we can give it for more than 6 cycles, 8 to 9. I have patients on 11, 12 cycles also. Now, how about PARP inhibitors? We have in triple negative breast cancer with BRCA mutation. Olympiad study used olaparib, 300 milligrams tablets versus chemotherapy of physician choice in patients who already had treatment, already had anthracyclines, taxane. This is what we get. Those are the standards. And they had less than 2 lines of 2 or less lines of treatment. Olaparib versus chemotherapy, which consisted either capecitabine, eribulin, or vinorelbine. And what we have seen, objective response rate much better when you use the PARP inhibitor, and also there was an improvement in progression-free survival from 4.2 to 7 months using olaparib. Side effects, most commonly what you really should remember is the anemia. A lot of these patients develop anemia, and we may have to usually reduce the dose. We may interrupt. Some patients require transfusion and reduce the dose. Overall survival was similar. So we do have a progression-free survival and a reasonable good toxicity as compared to chemotherapy. Now, other PARP inhibitors, talazoparib, used as a 1 milligram dose daily, again was compared to chemotherapy, physician choice. It was capecitabine, eribulin, gemcitabine, or vinorelbine. Here they, it's BRCA mutated patients, whether ER positive or ER negative, and you have a BRCA mutation. Again, those patients had prior treatment, and they were stratified accordingly. What were the results? That was updated at San Antonio 2 years ago, 3 years ago. The progression-free survival, significant improvement from 5.6 months, median to 7.2. So we have seen significant improvement with a hazard ratio of 0.54. Now, as for side effects, again, anemia is the most important. The dose recommended is 1 milligrams. After 2-3 months, these patients will develop anemia. We hold the drug. Some patients do require transfusion, but holding the drug, going down on the dose, 0.75 or 0.5 sometimes, and we have a good tolerance of this talazoparib. Now, other PARP, data we have is on PRO, patient-reported outcomes. In the talazoparib study, we have seen delayed deterioration of the health status. So we have an improved also aspect of patient-reported outcome. Now, the third PARP inhibitor used was veliparib. Veliparib was used with chemotherapy. Patients in the BRCA3 study had veliparib with carbopaclitaxel or placebo with carbopaclitaxel. And this study, again, also we have seen, improvement in adding veliparib to these patients. The overall response rate was 76%, 79%. Clinical benefit rate was similar, okay? There was some improvement of the progression-free survival. The toxicity, you see it here, all the toxicities with chemotherapy, with or without veliparib. You have seen, in addition to the anemia, thrombocytopenias as well, significant in these patients. One thing I'd like to mention also, the olaparib in metastatic breast cancer patient used, whether you do have BRCA mutation or other mutations. The TBCRC048 study just presented at ASCO 7 months ago, last year. This study did show a response, a 50% response in patients with BRCA mutation, but also interestingly, 92% responses, partial responses, in patients with PALB2 mutation. So that was an important finding, so we could use PARP inhibitors, also patients with other than BRCA mutation. Here, PALB2, the benefit was seen in patients with PALB2, more than the BRCA mutated patients. So what do guidelines say? We say that for ABC patients, genetic testings do have therapeutic implications and should be done, counseled and done. Patients with germline BRCA mutation, single agent PARP inhibitor, talazoparib or olaparib is the preferred option for those who have triple negative breast cancer, and the majority of the panel agree on this one. For patients now, the discussion goes on for patients with ER positive and germline mutation BRCA. Should we use PARP inhibitor or do endocrine therapy with CDK4/6 inhibitors? We don't know which one is better, which sequence is better, but the majority of the panel at ABC, we agreed that the majority rather uses CDK4/6 inhibitors before PARP inhibitors, mostly because they are better tolerated. Okay, now the Brocade, the panel did say that, okay, we do have a phase 3 trial, veliparib, a PARP inhibitor, but the initial data shows a small benefit in progression-free survival. We've seen it about 2 months. We have seen actually durable, as you saw on the graph. This small benefit is durable. So this is interesting, and we need more data and more follow-up on this study. And the last thing I will mention is immunotherapy. We know that these triple negative cancers have high mutation rate, T-cell infiltration, PD-L1 also expression, so it makes them prone to response to immunotherapy. And we had the Impassion 130 study that used atezolizumab with nab-paclitaxel compared to nab-paclitaxel alone. And we have seen a significant improvement in the program.
Sorry, we cannot hear.
Yeah, I think that we lost Professor Nagi. The connection is lost with Professor Nagi. So it was a very interesting presentation that actually Professor Nagi had highlighted the importance of, again, the personalized medicine and how can we much benefit from the biological profile of the patient, and it's really a heterogeneous and a complex disease is the triple negative breast cancer.